Good afternoon. This is Dr. John Bennett in the continuing series of an innovative conference we're having online, a neurosurgical conference. The title is Emerging Topics in Neurotrauma. And today we have the pleasure of having Corrado Iaccarino, a neurosurgeon from Parma, Italy. And he's going to be discussing topics in neurotrauma. Good day, Corrado.
Good day to you, and hello, everybody.
What they say, buongiorno.
Buongiorno, yes, you're right.
Okay,
afternoon today in Parma. It's afternoon, it's hot afternoon, but it's a good day.
Okay, could you do me a favor? Could you move the camera up a little bit? We're only seeing the top. We're not seeing your whole face. There we go. Okay, perfect. Okay.
Perfect. Well, okay, let me introduce briefly. I'm Corrado Iaccarino. I'm responsible of the TBI section of the Italian Society of Neurosurgery. And I work in an hub-and-spoke neurosurgery in Parma, Italy, in the University Hospital Parma, and in Scientific Institute Care and Research of Reggio Emilia. And I would like to thank Iaccarino because he invited me to this first ACNS program of education online. And he asked to me to talk about topic in neurotrauma. Do you see the slide?
Yes, we do.
Okay, let's go. And when we have to talk with trauma, we have to talk with trauma system. What is a trauma system? It's a system that have some phases of organization. And what is most interesting for a trauma system, and of course, we cannot imagine a unique trauma system, one trauma system for all over the world. Each part of the world should build this trauma system related to logistic, related to economics possibility. And so today we talk about this trauma system, how to build this one. First of all, there is a pre-hospital phases. And in this pre-hospital phases, we should think about logistic organization and also talk about the prevention of TBI. We know that epidemiology of traumatic brain injury show that traffic accidents is the main cause of TBI. All over the world, USA, Australia, China, Europe, there is recent papers of epidemiology of TBI. Also in Africa, Kenya, Uganda, Tanzania, or country where the road traffic injury is the real main problem for TBI. Also in Iran, motorbike and car accidents are the most responsible of TBI. This is an interesting study of Italian Institute of Health, and we see that from 1969 to 1999, the rate of death for road crashes is the same rate of death for TBI. So in Italy, the people who die for road crashes is the same people who die for TBI. For this reason, we are living now during the United Nations Decade of Action for Road Safety. And there are a lot of resolutions of United Nations General Assembly adopted for improving global road safety with the aim of World Health Organization. And we can find these 10 facts published at the site of WHO. And WHO say us how TBI is a real problem in the world, and how is important a good quality pre-hospital care to save many people for TBI. So the pre-hospital care is a really topic for TBI. Do the law save a life? Yes, of course. This is a report of Italian National Institute of Statistics, and in this period, in these 10 years, this is the number of deadly traffic road crashes on highway. And in 2007, we adopted an electronic speed camera control, safety tutor. After this adoption, the deadly traffic road crashes were reduced of 56.9%. So for the law saved all this life. Do the law help a neurosurgeon? Of course, yes. This is a Taiwan report. And we see in 1991 how the traffic accident caused the TBI in 66% in Taipei area and 80% in Hualien area. After 10 years, this percentage was reduced due to the helmet use law and drink driving law adoption. Also in Italy, in 1999, the helmet use law was adopted, and after 1 year, we observed a 66% of reduction of rate of admission of TBI in neurosurgery units. So polycycle prevention is a TBI topic. This is the first take-home message of this presentation. But the pre-hospital organization is a useful tool all over the world, has showed in these Saudi Journal Anesthesia reports, or also in this African Journal of Medicine, that they conclude, that mortality is high when pre-hospital care are not practiced. So organization pre-hospital management is a TBI topic. What about area protocols? The area protocols need to build sending image protocols and transferal patients protocols. Still now is debating if it's better to centralize all the neurosurgery, all the TBI, all the patients with TBI in a neurosurgery, or there is a need of selection, and some patients not need neurosurgery, and some patients need neurosurgery. Of course, if we adapt on the system of one single centralization, we need a lot of bed of ICU, a lot of neurosurgeon, and a lot of general practitioner. But this is an interesting report, recent report of the Health Technology Assessment in Britain. And of course, they say that direct transport of TBI in a neurosurgical centers could potentially improve outcome. But in the same way, if the patient are directly transferred in a neuroscience center without passing through non-specialist acute hospital, they can have some delay about stabilization, airway, breathing, circulation, and could impact on outcome. And the conclusion is, if we adopt a direct centralization, we have a over triage of patient with a ratio of 13:1 with suspected TBI and 4:1 with TBI. So for this reason, if we adopted a direct centralization, we need a lot of beds. In the real world, we have no so beds. In the real world like Europe, Asia, Africa, developing countries, we have much more patients to transfer and less beds where to accept these patients. So the solution for us is the protocol area with telemedicine system. And this system provides to define a proper selection of patient, to reduce the time between accident and admission, and to create effective means of communication. And of course, implement the common pre- and in-hospital standards for trauma care. Is the system cost effective? Of course, there is a lot of money to save without transfer unuseful patients. And this is a report in Italy, or northern Italy, how during the time the cost will be reduced and will be passed from the cost saving because we do not transfer unuseful patients. Is the system care effective? Of course. This is the two papers from the same group of Dr. Servedei, the president, elected president, the world neurosurgeon, my chief. And in this previous paper, without area protocol, of course, in the peripheral hospital, the unfavorable outcome was high. But with protocol, the outcome, unfavorable outcome in peripheral hospital was low. Of course, less than neurosurgical unit, because in this site with the right protocol, the patients are less complex and they can better. Also, these Turkish reports, they show that it's important, it's possible to manage a TBI for not neurosurgeon. Of course, in the first part of study, they show that the neurological examination was not so exactly. but after the not neurosurgeon learn how to do a correct neurological examination. So when there is a good organization, it's possible to have a good care. Of course, if we develop an area protocol, we take in account how is the logistic scenarios where the telemedicine could be applied. This is middle of Italy. Cesena is the city. Is a population about 1 million that during the summer can double, and there is a neurosurgical center and 5 hospitals, all connected with telemedicine system. The rate of transfer, the transferal rate is about 20% after first CT scan in neurosurgical unit, and after the second CT scan, 5%. About the same population, 1.5 million, but we are in Hong Kong, China, with 1 tertiary neurosurgical center, 3 kinds of telecounseling, and the rate of transferal in neurosurgical unit is about 6%. Of course, totally different situation in Durban, South Africa, where there is a population about 8 million for 1 public neurosurgical hospital. It's difficult to make some selection, and this is the rate of neurosurgical unit transfer, 83.6%. But what is interesting is just 16% require neurosurgery. So here we can propose in which model we are working now. Here, the hub-spoke model. In this area is a geographical area of 100 square kilometers with a population of 1,200,000 people, and we have 1 hub, spoke, a neurosurgical spoke. This is the particularity of this area, and 9 peripheral hospitals, all connected with telemedicine system, where in the hub is possible to check all these CT scans. And this is the rate of transferal in after about 1,000 cases of telecounseling, 20% is the rate of transferal. This is the transferal that we expect. What is particularity of this area is the neurosurgical spoke. We have hub, the hub is a high-level trauma center, and the neurosurgical spoke is a spoke where there is a neurosurgeon on site during the day and on call during the night. Why to organize a neurosurgical spoke? When do we need an hospital with a lower level of assistance for TBI? For example, in this case, of this 43 years patient with 15 Glasgow coma score on Sheen, with a drop just of 1 point at the emergency room admission, and the CT scan showed a posterior fossa extradural hematoma. So in this case, we have a high risk of rapid evolution, so it's possible to operate this patient in this case. Has no transferal in the hub. So the spoke neurosurgeon is a site where it's possible to treat pure TBI, where the neurosurgical spoke allows a timely treatment of these patients. And for us, it's important because we can avoid an hub workload. Of course, patients with polytrauma, with spinal cord injury that need a high level of expertise or trauma must be centralized in the hub. This is a report that we published about 353 patients with brain contusion in this organization, northwest of Emilia in Italy. And this is the results. And we see how in the hub there is a patient with high energy trauma, while in the spokes remain patient with no polytrauma, pure TBI. And how we say the percentage of patient with evolving lesion is low in the spokes. So this system works. We can centralize the patient that needs a high level of expertise. And we treat in the neurosurgical spoke patient that needs lower level of neurosurgical assistance. Of course, it's very important to organize protocols to transfer patients. because we must understand which patient should be transferred to neurosurgical unit. Of course, patient that need early surgery, patient for potential evolution, and we have to avoid to transfer hopeless cases. So in these two patients, we have a similar CT scan for the blood amount, but this is a patient 90 years with the Glasgow Coma Scale 14, admission I spoke, and this is a 82 years old patient after a fall with the same Glasgow Coma Scale. Of course, this sign of radiological potential evolution, like blood in here and blood here in subdural blood, make this patient in a potential evolution. And for this reason, this patient, the young patient, was transferred to the hub. During the transportation, his Glasgow Coma Scale drops to 12, and the second CT scan showed this huge contusion, while the other patient doesn't evolve. So the young patient was decompressed, and after 90 days was treated with a cranioplastic with a good recovery. So the third take-home message is that is it possible to understand which patient needs a neurosurgeon just on CT scan. So the surgical decision depends on multiple factors, radiological, clinical, and when available, physiopathological factors. And in a recent report of Angelo Polias of Cambridge Group, he suggests to discuss with neurosurgeons with severe TBI and moderate TBI. This is another report that we published in a book, teleradiology book, the first book about teleradiology, that we suggest that there is no way to talk about neurosurgery in two cases. In the mild TBI, because the neurosurgeon should not see this patient. There is a lot of guidelines for the treatment of the mild TBI. We adopted the Italian national guidelines. And another kind of patient is the patient with a clinical deterioration or open head injury. No time to talk about this patient. And he have to directly transfer it in the hub. But for the other patient, no comatose patient, and with a lower GCS than 14, with the CT scan telemedicine, we suggest to discuss case by case. For the other patient, all the other comatose patients, the protocol should take account the radiological signs and the clinical signs, and with telemedicine, we decide which best treatment for this kind of patient. What we are saying until now was published by European Brain Injury Consortium, and was and after an observational study in 66 centers, 24 countries, we understand that when a neurosurgeon decides to operate soon a patient, and when we say soon, we say under 24 hours, of course, the reason to operate this patient is mass effect. 60% of neurosurgeons, when we asked why you operate a patient soon, they answer mass effect. But of course, we know that we don't need any monitoring, any neurophysiological monitoring when we see this CT scan. We know that there are increased intracranial pressure. Also in this case, we know that there is an increase in intracranial pressure, and this patient needs a sudden neurosurgery. But when there is no clear mass effect, for example, in this case, 26 years, and a repeated CT scan after 8 hours from the first examination with a stable Glasgow Coma Scale of 11. What to do in these cases? Immediate surgery, surgical decision after clinical deterioration. or surgical decision after radiological evolution. And when we answer this case in a congress, in a meeting, to 16 neurosurgeons, we see that the answer was about equally distributed. This is the same thing that the report of European Brain Injury Consortium showed us. When the reason surgery is delayed after 24 hours, there is an equal value, the same value, or about increased intracranial pressure, clinical deterioration, or radiological deterioration. I mean, when a neurosurgeon has to decide if operate or not a patient after 24 hours, his decision is about not only radiological factor, not only neurophysiological factor, not only clinical deterioration, but the factor all together make a decision. And this is most important thing, because if there is all these factors, we need, of course, guidelines. And the guidelines drive the neurosurgery and neurointensivist in activities in a trauma system. We have guidelines. We have the Traumatic Brain Foundation guidelines published on neurosurgery. But if we have these guidelines, evidence-based, can we apply this all over the world? For example, we have, this is our ICU in Parma, and in 2015 we have 212 admissions. This is another ICU, a little bit far from us, Surabaya, Indonesia. This is courtesy of Dr. Erlanger, and we have in 1 year about 5,000 major emergency surgery. Or this other ICU in Ho Chi Minh City, 40 admission for 10 operations per day. So it's easy to understand that when we have an organization that allow the application of the guideline, the local guideline will be like the guideline, like in the first scenario that we see before in Cesena. The transfer protocol is very similar to the Brain Trauma Foundation guideline. But in this case, as we showed before, in the Durban, South Africa, when we have just one neurosurgery for 8 million people, the surgical criteria could be a little bit different from the Brain Trauma Foundation. And they decide to operate when the mass effect is over 30 centimeter cube, and if the midline shift is more than 10 millimeters. Of course, we have understand that in some cases the local guidelines could be different from the published guidelines. But it's very important the adherence of guidelines to define a quality of an hospital. And this is a report of Pacific Coast Surgical Association. And they study and they answer to this question. There is no association between hospital compliance with the Brain Trauma Foundation guidelines and risk-adjusted mortality. So they conclude that the application guidelines could be an independent marker of hospital quality. And what Professor Ganapati in India said recently, I take for the fourth take-home message. Guideline application must be related to the local available resource. Of course, it's better to have an area network to identify patients for transfer and treatment. And because we should avoid the overwhelming number of patients and useless family bankrupt. But it's important to understand that the guidelines should take in account where they could be applied. And in the world, there are totally agreement about guidelines. And for example, the intracranial pressure monitoring indication is a never-ending story. This is a report of National Survey USA in 2001, where we can see how are reluctant, the neurosurgeon, to place pressure monitors. And it's very high. It's very high. The neurosurgeon that do not apply the monitoring of intracranial pressure. Also, other report in this case of California, where the compliance with the Brain Trauma Foundation ICP monitoring guideline is about less than half of cases. Or in these other reports that the variability on ICP monitoring rates contribute only modestly to variability in institutional mortality rates. So they say that there are some other factors that could impact on mortality. What about, for example, to define ICP values? We know that the ICP values about 20 millimeter is defined by Marmaro in the 1991. But nobody knows the normal trends of intracranial pressure in patient awake or with high Glasgow Coma Scale. This is my report. Is more than 10 years ago. I was studying the cranial pressure after endoscopy, neuroendoscope, and I monitored awake patient with 15 Glasgow Coma Scale with a bedside monitoring, and this red line is 20 of ECP value. Look at how many people have a high intracranial pressure. Also 40 the first day after neuroendoscopy procedures, and they was awake. And this is another paper, and with more patients, and the patients are divided for pathology. This is patient with aqueductal stenosis. These other patients is 4 or 5 patients with shunt malfunction group, and other patient with ventricular lesion, and only the patient treated with the third ventriculostomy with endoscope with this kind of pathology, extrinsic aqueductal compression, they show after surgery decrease under 20 of intracranial pressure. But all these patients, during the first days after third ventriculostomy, they show pressure, intracranial pressure more than 20. Anyway, in this report on New England Journal of Medicine that explain the intensivist management of TBI with the step. Each step depends on maintaining acceptable ICP or CPP value. In according between neurosurgeon, intensivist, of course, is mandatory. But still now, 2014, the ICP value drive the intensivist maneuvers. But we should pay attention because we could have some wrong conclusion. For example, in the first version of the guideline for the treatment of cerebral perfusion pressure, we supposed to keep the patient above 70, but this cause adult respiratory distress syndrome. So during the developing of guideline, we can change some conclusion. Because strong guidelines need strong evidence, and we do not have this strong evidence, especially for intracranial pressure. We have just level 3. There is a combination that say that a combination of intracranial pressure value, clinical and radiological finding should be used to determine the need for treatment. Still, once again, the decision is a combined factors of clinical, radiological, neurophysiological factors. There are insufficient data of level 1 to understand the value of intracranial pressure in the treatment of TBI. There are only one, this one of 1988, only one prospective controlled trial that talk about take the intracranial pressure below 20. Of course, for this reason, during this year, we say a literature define critical about the impact of management based on maintaining ICP values on outcome of traumatic brain injury patient. Kramer, Shafi, Cooper, Chestnut, they are the main authors. There are, I mean, against, not against, they are critical on ICP values. And the main argument is the lack of evidence about results. They say fundamental, no randomized trial, the benefits are unclear, two different protocols. And they conclude in their reports that we need prospective randomized controlled trial, and they also conclude that there is no better outcome. Sometimes we have more complication if we treat patient with following the ICP values. But we must carefully analyze the literature. We do not read only the abstract to modify our clinical practice. It's better to fully understand this kind of literature because they just suggest that we have to understand better the intracranial pressure value and how we use it. Kramer, the first of them, they suggest just that ICP monitoring is not a standard of care. He say not that we have to avoid. So Shafi, he suggests just that 20 is a value that identify some group of patients, and we have to understand what to do with this patient. The randomized trial is a good evidence, good quality of evidence of Cooper, the DECRA, and they of course showed that after the compressive craniectomy, the pressure is normalized. The patient with a standard CAT treated without the compressive has an intracranial pressure higher than the patient treated with the compressive craniectomy, of course. But what DECRA show us that the unforgivable outcome of this patient was unbelievable because the compressive craniectomy patient has 70% of unfavorable outcome, while the patient not decompressed, 51%. No very different about the dead patient. And also the report of Randy Chestnut, the last one, is another report that randomized patient treated without monitoring of intracranial pressure and patient treated with monitoring of intracranial pressure, at the end conclude that there is no difference about outcome if we treat the patient with intracranial pressure in monitoring or without intracranial pressure monitoring. So apparently it seems that the manipulating intracranial pressure do not produce improved recovery. So apparently this literature say us that monitoring of intracranial pressure could be unuseful or dangerous. But it's not true. What Randy Chestnut say and published it, and again he say around the world, that the issue of contention of this work is not about the intracranial pressure value, but about to understand the threshold of the value and what we have to do with this intracranial pressure. Randy Chestnut and all the authors before him say that we have to change our decision about intracranial pressure. We have to better understand what to do with this value. Of course, all these reports suggest that we have to abandon the holy grail approach for the value of 20 of intracranial pressure. recently, Leroux published this message that I can say that is very useful to understand the management of the TBI. We have not to accept 20 like absolute value, but we understand that there are, we have to tailor the threshold on the patient, the characteristic of patient, pathology, other physiological parameters. And ECP values become an epiphenomenon. I mean, the monitoring intracranial pressure is just a value that are mixed with other value like ischemia, hypoxia, cellular dysfunction, and taking in account of this, all of this, we can understand better the treatment of TBI. Of course, when it's possible, because if we have to take into account all this value, we need a multimodal monitoring, and this is right now no mandatory because we have no evidence about the utility of this kind of monitoring. So for now, what we have to change after all these literature analysis, we have to understand that for the present we can accept reasonable a threshold of intracranial pressure 20-25 because there is a variable in this patient. We cannot accept more just 20 like threshold. Of course, another answer is, so what to do when we have to monitor a patient? And for this reason, the Italian neurosurgeon, European neurosurgeon, and American neurosurgeon meets in Milan, in the Milan Consensus Conference that was published in Acta Neurochirurgica. And this was organized by Italian Society Neurosurgery, the European Association of Neurosurgical Society, endorsed by Franco Servadei, the elected president of World Federation. And here there is Randy Chestnut. Of course, we start the meeting after reading his paper. And we publish all the recommendation. And this is another important word, recommendation. We cannot define guideline because for the level of evidence that we have, we can just define a recommendation, new recommendation for intracranial pressure monitoring. And we analyze all these scenarios and what to do after a post-traumatic coma and CT scan. First, changing after Milan consensus. Before ICP consensus, the Brain Trauma Foundation guidelines suggest to monitoring ICP in all patients over 40 years with unilateral bilateral model posturing. But after ICP consensus, the monitoring the intracranial pressure in the comatose TBI patient with a normal CT scan is generally not recommended. So, before the ECP consensus of Milan, the Brain Trauma Foundation suggests to monitor all the patients with a Glasgow Coma Scale lower than 8, especially if they have 40 years. After the ICP consensus, we recommend do not monitor this patient. Of course, there is no change about the concept of the worst CT scan. The most important CT scan in a TBI is not the first one, but the second one. Because in the second one, we see the really situation, or the situation that could be in the future. Again, if in the first CT scan we see post-traumatic subarachnoid hemorrhages or petechia, small petechia, another changing of the Milan Consensus Conference that we don't need intracranial pressure monitoring. If at the first CT scan we see these radiological findings, we don't need ICP monitoring. So we expect the second CT scan. If also in the second CT scan, the CT scan is unchanged and there are still small petechia, or traumatic subarachnoid hemorrhages, we don't need monitoring. Otherwise, if we see progression of the petechia, or we have high intracranial pressure signs, we do monitoring. About intracranial pressure signs, we know comatose patient with midline shift, effacement of basal system, disappearing cortical sulci, undistinguished gray white matter, diffuse hypodensity. All these signs need a monitoring of intracranial pressure. Like in these two cases, on the left side, the A case is a girl, 32 years, and with a Glasgow Coma Scale Motor 3 on scene. She was intubated and transported by helicopter to neurosurgery with a Glasgow Coma Scale Motor 5 at admission. The B cases on the left side is a 15 years patient with the same Glasgow Coma Motor machine and transported with ambulance to neurosurgery. At admission, the Glasgow Coma Motor scale was 1. Both of them was monitored. The first case, the A case, showed a intracranial pressure value under 20, and after 12 hours, the CT scan was the same, and we extubate the patient. While the B case, the guy showed intracranial pressure value more than 20. So this situation was unchanged with the same CT scan first 8 days post-trauma. So the second patient was decompressed because any intensivist maneuvers was not able to reduce intracranial pressure. So the take-home message is that intracranial pressure driven surgery could have still now a role in the neurosurgery of TBI, and it's the topic of the TBI. Still now we have to discuss about intracranial pressure. What about the brain contusion by Milan Consensus Conference? The Milan Consensus Conference take in account a lot of paper in literature about frontal contusion, huge frontal contusion, and they need for sure monitoring. The peculiarity of contusion is the progression. We know that contusion can progress 2 peaks. The first peaks during the first 2 days, the second peaks about the 5 days. And so we need to monitor the clinical parameters, neurological parameters, neurophysiological parameters when available. And we know that these parameters do not have the same evolutive behavior. For example, in this paper that we studied 352 patients, we see how in the first 12 hours post-trauma, the clinical parameter and CT parameter have different behavior. The clinical parameter, 31% about of the patient show a clinical deterioration, but more than half of these patients have a radiological evolution. So the radiological evolution is more important than clinical evolution. In the same way, 6% of patients, very small rate of patients, showed a clinical improvement, and more than 10 patients, then more than 10 patients showed a diminution of lesion volume. But it's very interesting to see that more than half of patients, 2/3 of patients, showed a neurological stability, while the radiological stability is just 1/3. So we need to follow all these parameters to understand what is the most important factor to understand which contusion can evolve. And what we say that on radiological finding, midline shift and basal system are the most important parameters to preview the brain contusion. It's very difficult to follow the contusion. There are some limits for clinical monitoring and some limit for radiological monitoring. So the ICP in this case is very useful. Can anticipate the scheduled CT scan control, for, like in this case, because we have a rise of intracranial pressure after 2 hours. So we perform a CT scan that shows a radiological deterioration. Or in this case, after surgery, we monitor the patient after surgery and the rise of intracranial pressure announced us that there was some problem that CT scan show. Otherwise, the ICP monitoring can allow a delayed CT scan control. For example, we have this patient with more than one contusion, small contusion, and after the first CT scan, we should perform a CT scan after 60 hours, but the second CT scan was performed 9 hours later because there are abuse in ICU. And we was quiet because the value intracranial pressure was normal. So we suppose that we can we can delay the CT scan. Still, the ECP driven surgery there is a rule, like in this case, this contusion. We have a contusion, frontal contusion, with the monitoring of normal value for the first 5 days. By the 6th days, in the 6th days, we have an onset and rapid increase of intracranial pressure. So we operate this patient with the compress this patient. Other suggestion, other recommendation of Milan Consensus Conference about the intracranial pressure monitoring after surgery. After surgery, I mean after evacuation of intracranial traumatic hematoma, or after evacuation and decompression. And the Milan Consensus Conference suggests in this case we are still in a, how can I say, not experimental, but we have still to understand why the intracranial pressure is rise, and so all the consideration of intracranial pressure monitoring after surgery is still needs evaluation, still needs to understand better the behavior. It's a practical tool that we have, but we cannot decide with high level of evidence what to do with the intracranial pressure value after surgery. And this is our experience to contribute some evidence. And this is a study of 34 patients. We monitored the patient after surgery. And of course, in 3 cases, the intracranial pressure suggests us to put a CSF drainage, in 4 cases to perform another craniotomy. Like in this case, female 75 years, pedestrian with a Glasgow Coma scale of 5. And this is the CT scan before the first decompression. And after operation, during the intracranial pressure monitoring, we have a rise intracranial pressure values. So we perform the other CT scan, and we make a reintervention with contusion removal and temporal uncus resection with decrease of intracranial pressure value. What we see in our casuistic, what we see in our series of patients, that ICP value after decompression is correlated with outcome. I mean, we follow this patient, and of course, monitoring intracranial pressure after surgery, it was useful to understand when it was necessary to reoperate this patient. So the monitoring of intracranial pressure after surgery can be useful to save some patients. But what was more interesting, also if we analyzed just 34 patients, that the intracranial pressure value after the compression is correlated with outcome. The patient that have low value of intracranial pressure has a better outcome. So, and finally, what's new about consensus conference? Consensus conference suggests speculative approaches. We have to think about risk and benefit of intracranial pressure monitoring. We have to abandon the holy rule of 20 of intracranial pressure threshold, and we assume that monitoring is indicated when there is a serious concern for the risk of herniation. Practical approach, we should monitor the intracranial pressure when we have no so sure about clinical condition. And of course, the intracranial pressure monitoring is unuseful. It's not recommended in diffuse injury 1 and 2 of the Marshall classification. Is unuseful in diffuse axonal injury in the elderly patients. So the take-home message about all this talk about intracranial pressure is if you have a limited resource, intracranial pressure monitoring is not mandatory. If you have few money, it's better that you organize your TBI management for something better that have more reliable significativity and more reliable evidence to be useful in the management of TBI. And if you can monitor the intracranial pressure, for sure you can monitor in patients that show a potential evolving lesion, even preoperatively, even after operation. Because about ethical consideration, we try to avoid to treat unsalvageable patient. For example, in this kind of patient, when we ask to European neurosurgeon what to do in a European neurosurgery course, more than 2/3 of patients want to operate, want to centralize this patient, and 60% want to operate this patient. But there are a lot of patients that are, they don't need, maybe they don't need surgery, like this young patient with all of huge contusion, including brainstem contusion, but it was operated. And he was in a persistent vegetative state for 6 years, and after he died. So the question is how to understand which prognosis will have our patient. It's difficult to understand. We could have some tools to prevent, to have some prognostic factors. But for example, this is two main tools, the crash and the impact. And for a same kind of patient, 41 years with a diffuse injury 4 of Marshall classification, is the same patient. The crash say that we have 86% risk of unfavorable outcome. The impact say that this patient has 75% of unfavorable outcome probability. So the same patient is judged in different way from system of previous outcome or prevedibility of outcome. So the take-home on the 19 take-home message is surgery is not for unsalvageable patient. At the end, how to forget? It's impossible to not forget rehabilitation. For the trauma system needs a good rehabilitation project, and this is a recently Deepak Gupta published on World Neurosurgery this wonderful paper where he compared level 1 trauma center in India and the Harborview Medical Center in USA, and comparing the guideline adherence. The two centers were very similar on overall ICU adherence rate, 74.9% in India, 71.6% in USA, and 90% adherence of follow indication. I mean, the treatment in this center was very similar. The results similar, In hospital mortality in India, 24%, in USA, 26.5%. 4 is the most common discharge ghost score. What was the difference in these two situations? Was the post-discharge treatment. In India, 80% returned to baseline level of functioning discharge. 72% of patients were discharged home. No patient received inpatient rehabilitation. Only 4% of patients received outpatient rehabilitation care. In USA, instead, 21% patients returned to baseline level of functioning at discharge. 16% were discharged home, and 27% were discharged to rehabilitation facility, and 26% have a skilled nursing facilities. I mean, quite 0.5% of patients received rehabilitation or skilled nursing facilities, while no patient received any kind of assistance after discharge in India. And this was the difference that influenced mortality. Mortality in India, died patient 24% at discharge, 29% at 3 months, 34% at 6 months, and 36% after 12 months. While after discharging in USA Center, there was only 1 new known death. So, because of until discharging, the management, the results, mortality, goals was the same. The mortality was dramatically different between two systems, and for sure the absence of a post-discharging assistance impact in a dramatic way on the results. So for this reason, the commentary that Franco Servadei wrote on World Neurosurgery is the 10th take-home message. Please don't forget post-acute care. The articles of Gupta show as is important the post-hospital and rehabilitation care. So not only physicians, also public administrators should pay very, very high attention on this problem. So if we finish with the same slide how we start, this is the take-home message for each phases of trauma system. For the pre-hospital, don't forget also about prevention and the pre-hospital management. About protocols, guidelines application must be related to the local available resource. And the surgical decision in these protocols take account of a lot of factors. Like when you build an area protocols, all these factors could be taken in consideration. About the neurosurgery and neurointensivist management, we understand that intracranial pressure driven surgery could have a role in TBI management, because still now we don't have a so high level of evidence. The threshold is changing in these last years about the intracranial pressure good values, and for all these reasons, if you have no resource, it's better that intracranial pressure is not a priority in your TBI organization. Anyhow, ICB monitoring is very useful in the potential evolving lesion, and surgery cannot cure unsalvageable patients. And finally, don't forget the post-acute care. Thank you very much for the attention and for the time.
Okay, Corrado, excellent, excellent. You can get off that screen share. Just click on the green arrow to get off it, please. Yeah, excellent presentation, great illustrations, very clear. And I stress that we're new with this technology of Hangouts, because I think in the future, once the neurosurgical community realizes that a tool like this is available to see such an excellent presentation on the computer that hopefully will have people worldwide seeing such a quality presentation as this one was. And certainly neurosurgeons and neurosurgical residents and students will be able to continue to see this video on YouTube and on neurosurgical TV. Now, I just have a few comments. I'm not a neurosurgeon. I'm a general practitioner that I did a fair amount of work in the emergency room. And I do understand your point about the ICP. It's kind of similar to me to fever. You know, a physician is taught you don't treat the fever. You look what is causing the fever. Just like you were saying about ICP. You're not only concentrated on the ICP, you look at, well, what's causing the ICP to go up? Do you have any comments on that?
So?
Yes, yeah, a couple of things. You know, in transferring patients, which I was involved in the emergency room, I wasn't a neurosurgeon, an emergency doctor. We found that most hospitals can handle multi-system trauma. Every hospital has a cardiologist, every hospital has orthopedists, intensivists, but not every hospital has a neurosurgeon. So that's the determining factor on whether or not a patient gets transferred. And you know, in America, it's the same as Italy. No, there's not only so many neurosurgeons, and most of the time, we had a pretty difficult time transferring because neurosurgeons are so busy; they're hard to get a hold of. Is the situation the same in Italy? I imagine it's probably the same.
Yes, the situation is similar, but I told you the trauma system is a system that developing with meeting, and when we build the trauma system of our area, we build the trauma system not only between neurosurgeon and neurointensivist. We build the trauma system with the physician of the emergency room, physician of the transportation of the patient. We build the system with all the physicians of the emergency area. So we developed the protocol. When we leave a patient with a small hematoma in a peripheral hospital, we leave a patient not in a hospital that we don't know any kind of this hematoma, because we talk with this physician. We have some. There is each 3 months, 4 months we meet to talk about the patient that are difficult patient. If we have some difficulty with patients, we talk and we make what we say audit. I mean, there is a case, we have understand why that patient arrived with 2 hours delay, or because a patient was centralized and maybe that patient doesn't need centralization. I mean, trauma system is not a fixed system; it's an active system, and the heart of the system is communication, share communication, share experience, because the protocols can change. Because can change logistic. So this is the trauma system. This is the way, because I divide the trauma system in pre-hospital protocols, neurosurgery, rehabilitation, because each box has a story. Each box has a kind of organization with meeting with the people who works in that works. The people's works for pre-hospital organization, the people's work for the protocols. When we develop protocols of area of centralization or transferring imaging, the people who works just not only physicians, also the people who works with the CT scan, with the MRI, the technician of imaging works with us to develop the best way to transfer imaging. because we can use internet, or we can use we can use the PACS, the system of the hospital. Of course, there is some restriction by the law, by the privacy. We cannot use open line to transfer imaging of a patient.
Mm-hmm.
So
one more thing, based upon you said that clear surgical indications are based on imaging, and there are some hospitals. I don't know, small hospitals in Italy have most of them. Some of them don't have CAT scans, correct?
About that, I was talking on you.
Yeah, some do all hospitals have CAT scans in Italy, or just the bigger ones?
No, also the small one. As I show you in our area, we have 3 main hospitals, and after 9 lower hospitals, all these hospitals have a CT scan 24 hours.
Oh,
there are also little hospitals without CT scan facilities, or with the CT scan just during the day, not during the night. And this little hospital cannot participate to the area of TBI management. So when you build the trauma system, you build a system where you need the peripheral hospital with the CT scan 24 hours on 24.
Okay. Will you ever take a transfer without seeing a CT scan, or you won't? Because I know how important it is, but there might be some instances where it's very emergent, and you may not be able to get a CT.
We transfer the imaging with directly with the off-site workstation. I mean, as I show you, we have 3 different main districts, and in our case, we have off-site workstation of the 2 hospitals directly on the desk of the hub. So on the desk of the hub, we have the PACS system, the system of imaging of that hospital, and we have other 2 videos with off-site workstation. So the connection is direct, is protected. We can share the imaging without any problem about privacy.
You know, other than imaging, do you are you ever able to see an image of the patient on a camera, or where you actually can see the patient?
No,
or that's not important.
There was a project. There was a project in another city of Italy. Casetta is still in developing to make a camera, a 4G camera, to see the patient. But we don't see the patient when we make a connection. We have a form from the peripheral hospital. In the form of the peripheral hospital, we have all the condition of the patient, dynamic of trauma, also all the data of patient age and where he live, and so we don't need to see the patient. We have a phone by peripheral hospital, so the general practitioner say us how is the patient. So there is a first contact by telephone. After we receive a fax where there is a form with all the findings of the patient and the description of the CT scan. So in this way, we don't need to see the patient.
Very good. Okay, Corrado, I'd like to thank you very much for taking your time out on probably one of your days off, and we look forward to having more presentations by you. So thank you very much.
You're welcome. You're welcome.